I'm really excited to see some new faces in the audience. I'm even glad to see some old faces here, even though they're shills on the baseball team. He's ignoring me. It's what he does. He just ignores me all the time. So, my introduction today. One of the challenges you've heard from us over the last, 5 years, maybe longer, is we're working very hard to create standard work in approaching many of the diagnoses of the children who come to this institution. We believe that by doing that, we can actually begin to improve care and make that care better. What Ben's going to talk to you today about is how that may not be looked at in the same way by a variety of audiences that we serve. And this challenge of just because we've been doing it forever, can we do it better and how can we study that? Ben?
Great. Thank you, Tom. It's a pleasure to be here and to chat with you guys today about some issues I think are really very important and very interesting. And I'm going to begin taking off cue from Tom to say that there's a lot of different ways that we try to improve medical practices through different activities that broadly can be thought of as research. But often, depending upon how we label these, we often approach them differently from a regulatory perspective. And yet there really is a lot of overlap between these. And today, a big part of what I'll be doing is focusing on things that often are put into this category of comparative effectiveness research. So I've got 3 objectives for my talk today. The first is to tell you a story about a randomized study of oxygen saturation levels in the NICU and why this was described in a New York Times editorial as startling and deplorable. Second, I'll tell you why the regulatory agency, the Office of Human Research Protections, thinks that research in medical practices using randomization is substantially risky. And finally, I want to explain to you how the public has different views than OHRP does about the role of informed consent for this type of research. Now often for grand rounds we have disclosures, and so my disclosures, I guess I also described as perspectives, because this kind of gives you an explanation of where am I coming from to help you sort of understand my perspectives and thinking about these issues. So first, as a bioethics scholar, for years I have studied informed consent and have done a variety of projects related to informed consent. As a former IRB chair and data safety monitoring committee, I realized that oversight can be very challenging and hard to do well. And finally, as a pediatric pulmonologist, I take care of babies in the NICU, and one of the stories I'll be telling you about really comes from that environment. I've been fortunate to have grant funding to do 2 different projects related to this topic, and in the last 2 years I've had about 7 papers or letters published in this area and have a few more in press. So it's been a lot of, for me, this is where I've been spending my time when I'm not doing other things, and I really have been having a lot of fun with this. And I'll begin by giving you the story, and my entire talk really is a narrative, kind of like Star Wars. And I put this slide on there initially because I like the initial logo long time ago in a galaxy far, far away. But in fact, it really wasn't that far long ago. But more importantly, I realized this morning as I was driving in that what's really nice about the Star Wars metaphor is that the story I'm about to tell you is one that is generally described as a story between good and evil. The problem is everybody thinks they're Luke Skywalker, and they think that everybody else is Darth Vader. And so the story here had to do with a clinical dilemma that neonatologists faced, which was what was the best range for target oxygen saturations. The recommendations by the early 2000s were to use somewhere between the 85 and 95% of oxygen saturation targets for kids in the NICU. But there was uncertainty whether or not this was the right range, whether this range could be more narrow. Was it better to be on the higher side or the lower side? This was such an important question that there were 5 international studies done trying to answer this question. One of these studies was done in the United States. It was called the SUPPORT trial and involved over 1,300 infants at 23 different institutions. And the SUPPORT trial actually looked at 2 different issues separately in a factorial design. One included issues in the delivery room regarding surfactant versus CPAP, and the second had to do with those oxygen target saturations in the NICU. And the way they approached this was to have some kids assigned to the lower side, other kids assigned to the higher side, and the way they accomplished this was to have a protocol where the oximeters were altered so they all would read between 88 and 92%, regardless of which of those 2 ranges they were in. This is all grand rounds has to have some slide of some data, so this is my slide of a graph with some data on it. But it's actually important. This is from the paper that came out of the support trial. And the thing I want to actually point out is that when you look at the actual median oxygen saturation levels for the two groups, they overlapped a lot. And in fact, it turned out when they analyzed the data, there was no difference between the two groups. That did not stop them from getting this published in the New England Journal of Medicine for a variety of reasons. And while the target composite primary endpoint, which was severe retinopathy or death, did not differ between the two groups, they went in different directions. So severe retinopathy was less common in the lower target saturation group, but death before discharge was slightly more likely in the high oxygen saturation group. So those two issues canceled themselves out. 3 years later, after the study was published, the University of Alabama received a letter from the Office of Human Research Protections about this study. And they had made 3 determinations. First, they decided that the investigators incorrectly believed, because all infants were randomized to oxygen saturations within the standard range, that it follows that the study involved no more than minimal risk. Secondly, the risks of randomization made it more likely that there would be differences in outcomes of the two groups, including death, neurologic problems, and ROP, and that the informed consent form did not adequately describe any reasonable and foreseeable risks. The form should have explained, this is perhaps the most important point, that the study involved substantial risks. And so I wanted to give you some information about the consent forms, and I think this will help you understand where OHRP was coming from. And I do think that OHRP did have a legitimate point in saying these consent forms could have been better. As I'm sure with any consent form you show me, I can show you how it can be better. So here's what went on there, and this is really a theme of my entire talk. It has to do with how we describe the purpose and how we describe the risks and benefits, and where we place different pieces of information, and how we categorize that. And I think what I want to draw your attention to is the second sentence about the benefits, which is from the UCSD form. It says here, because all the treatments proposed in the study are standard of care, there's no predictable increase of risk in your baby. Then it goes on to say, but there might be benefits directly, including a decrease of lung disease as a result of. And so the point here is that either there was no risk and no benefits, or if there were benefits, there were risks. And they kind of hedged their bets in a kind of a strange way. I personally think the answer was there were really no risks or benefits to you from being in this study. But the purpose of the study was to learn whether these interventions were better. And that's a very important distinction. It's debatable, but that's really what I hope over the course of the day will convey that to you better. Now, in spite of what I just said, this is what the New York Times said. They decided that the informed consent form was so bad that the form failed to accurately describe the risks and benefits, and that this failure was startling and deplorable. This is actually when I got involved. I was actually at this time visiting my mother in Florida, and I was cleaning out. She was moving to an assisted living facility, and I was cleaning out some stuff and it turned out I found some clippings that she had saved from when I was in college. And there was an interesting article in the newspaper, because when I was in college, as a sophomore, I helped organize a petition for a faculty member who had been denied tenure. And I got over half of the student body to sign this petition. And the article in the newspaper was actually kind of interesting, because the article was taking the perspective of, this is really interesting. Here are two people who, instead of spending their time drinking beer in the evenings, they're organizing this petition. That's really how it was. And I thought about that, and I thought, I don't have time for those types of sort of quixotic quests to try to fix things when I see them broken in the distance. I got too much work to do. And I thought about this article, and I thought, this is something I should get involved with. This is really, the fact that the New York Times is looking at this study and describing it this way is too much to bear for me. So what I ended up doing is getting, over time, I started talking to more people about this, and I got 45 other people together, and we wrote a letter to OHRP that we that was published in the New England Journal of Medicine in the summer of 2013. And we suggested that while the permission forms could have been improved, we disagreed that the random assignment of infants imposed additional risks. that the investigators failed to expose. And that's really the critical issue here, is that whether or not that the study imposed additional risks. Now, 2 weeks later, there was another letter in the New England Journal disagreeing with our letter. Of course, the way we can know that we were correct is because we had 46, they had 45. But I think that more seriously, the distinction between the two groups is that I was looking at the study as a whole. My primary focus was what is the risks of the study and an assessment of those risks. Whereas I think the group on the other side were looking at the consent forms, which were problematic, and saying, we don't like these consent forms. And I think there's a difference between whether you're looking at a consent form and how you view the role of a consent form in thinking about the ethics of a trial versus how you think about the entire trial and what the injuries and harms are to children in the trial. Which is not to say that informed consent is not important. In fact, as you'll see, I think the challenge is we've kind of gotten ourselves into a paradoxical place where we actually do a worse job of informed consent than we could do. And that's part of what I'm trying to improve over time. What happened next was that, which was unprecedented, that OHRP held a public hearing on August 28th, 2013. It was quite an interesting exercise, and if you are tired on a Saturday afternoon and want to go onto YouTube, you can watch the entire set of presentations. Each one is 7 minutes long, followed by 5 minutes of questions from different people. And this was literally 7 minutes per person because the moderator stopped you at 7 minutes, and by 7:15 the microphone got turned off at 15 seconds later, so you could not keep talking. So it was fun. And so this was on August 28th, 2013 rather. A year later, as OHRP published its draft guidance, and here's what they said. The reasonable foreseeable risks of research is a category of information that needs to be included in consent forms as a risk of research. So I'm just explaining that to you as background. And so it says that the reasonable foreseeable risks of research in a study includes the already identifiable risk of the standard of care being evaluated as a purpose of the research, when those risks being evaluated are different from the risks some of the subjects would have exposed outside the study. So for them, death was a risk of the research of the support study. Death is a risk of every single cystic fibrosis study we ever do because kids can die with cystic fibrosis. So since I'm seeing Ron and Greg here, the idea here is that every single nutrition study you do, if you measure death, you have to tell them the risk of the study is death. That's what this study says. I thought this was wrong. My colleague David Magnus, who's my collaborator on these two projects I mentioned before, we wrote a letter that was published in Pediatrics in 3 months later. And the key point here that I want to draw your attention to begin with is what's down at the bottom, which says that if the risks are exaggerated, number one, it'll make it harder to recruit people into research, but more importantly, they'll misattribute the unavoidable risks of clinical care as avoidable risks of research. And this is really the problem for me. It's not about consent, it's about how do you think about what's going on? And should a person who is in a nutritional study for cystic fibrosis or in any study in the NICU where there is a risk of death, should they attribute that death, if that does occur, to being in that research or not? So I'm going to say a few more comments about this draft guidance because I want to use this as a setup so you understand what the issues are, because I'll come back to that at the very end. And there's a number of different issues here. The first I want to draw your attention to is something that is this term standard of care. This was a term that OHRP used in its memos. It's also the term that the UCSD used in its informed consent form. This is a really not good term to use, I think, in any sort of conversation that we have in clinical practice. Standard of care is a legal floor in which we use to assign negligence. So if somebody is short of breath, is blue, and you don't listen to their lungs, you have not succeeded at the standard of care. But there's a lot of usual practice variation that occurs between institutions and providers above that standard of care. And the issues that we're trying to address are issues about practice variation, not about the standard of care at that low level. The other thing, and this is what I was bringing up before, is that OHRP mischaracterized the purpose of the research, which should be disclosed as a purpose, as a risk. And therefore, it misidentifies minimal risk research as greater than minimal risk research. And it suggests that the uncertainty of outcomes becomes a risk of research when they're studied, But when the outcomes occur when they're not studied, they're not a risk of research, and that doesn't make sense. It also ignores the methodological necessity of measuring death. When you have a population in which death can occur, if you don't measure death as part of your study, you'll have biased information. So it's necessary to measure death, but measuring death doesn't mean that you've caused death. And the ultimate issue, which I brought up before, is that this can mislead participants about the riskiness of the research and suggest that these are risks or harms that can be avoided by not being in the research. Now, I think this was most eloquently described by a journalist who had a premature baby, who wrote an article in the Tampa Bay Times in October of 2013. And I would encourage you to look at this essay. It's beautifully written. It describes her experience being in the NICU. It also describes her reflections about the support study. And you can see by the provocative title, which I want to begin with, one of the I thought was the most interesting line that she said. She described signing forms for routine stuff. And she said, signing those forms was my first official act as her mother. And the responsibilities made my cheeks hot. But I didn't read a single one. The only thing I remember about any of those forms was how it felt to write my name right next to my name that I was her mom. So that was what signing the forms was for her. She then goes on later, she's talking now, her daughter is actually grown up, she's got through the NICU as most kids do. But she says, had I been asked, I probably would have signed her up for a research study. If things had gone well, I might have believed the study had helped. If things had gone poorly, I might have blamed the study and fear I'd been duped. To me, this for me justified or validated why I got engaged by this in the first place. To me, it was this type of concern that somehow the relationship of the research to the outcome in a very explicit way, I would feel terrible if for those kids in the support study who did die, that they view the death of their children based upon a decision they made to be in that study. I think that would be a mischaracterization of their decision making and of what they did. And to have parents live with thinking that they caused their kids to die because they made a bad decision, I think would be tragic. So one of the things we do in bioethics is we try to generate new knowledge, we try to think about things, we try to ask questions, and we do that two different ways. We can do that empirically as well as normatively. Normatively, the question is, well actually empirically, one of the questions is, what do the public think about these questions about randomization within usual clinical practices? What do IRBs think about this? So what I'll be doing is telling you a bit more about some work that I did to learn more about attitudes about these issues. And secondly, this raises a normative question, a value question about how should those attitudes influence what our policy ought to be as it relates to risk assessment and approaches to informed consent. And these are like everything else, these are ongoing questions, but I'll give you some ideas about this. So for the last 2 years, I've been involved with a collaborative team that you can see. The main thing to show you is there's a lot of people in this group. There's an inner circle, there's an outer circle. We have collaborators, and it's been a lot of fun. And we have weeks of conference calls twice a week, which have been going on for now quite a while. And I'm going to tell you about, I don't have time to tell you about all the studies and all the projects we've done, but I'll give you some flavor of the scope of them, and I'll hone in on one of the studies in particular. So we've done a number of different things. We have studied both IRBs and people from the public. We've done focus groups. We've done surveys. And mainly I'll be focusing, see if I can get this pointer to work. There you go. I'll be mainly focusing on this, on the public survey, but I'll say a little bit more about our public focus groups, and I'll give you a brief bit of information about our IRB survey as well. The challenge we faced in doing these projects was realizing that assessing public attitudes is not easy when people may not be familiar with the issues we're dealing with. So here's a list of some of these issues. And these are not things that roll off your tongue very well, and that most of the public can speak eloquently about learning health systems and comparative effectiveness research. So our challenge is, how do we explain these things? And because we want to give enough information so they understand the central concepts. Also, as I was describing, there's a lot of angst about this. So trying to figure out how to do this in a balanced way was challenging. And one of the ways, so what we did is that we actually decided to make 3 animated videos describing variation in usual practice, describing research and medical practices, including medical record review and randomization, and talking about 3 different approaches to patient engagement, including providing general information, having a discussion and verbal permission, as well as written permission. We also intentionally chose to describe these activities as research and medical practices because we thought comparative effectiveness research is too clunky. Nobody has any idea what that means. Standard of care is simply wrong. And so the best thing we could come up with was the idea of research and medical practices. And the purpose here was to be very intentional, though, about calling it research and saying this is research, rather than saying it's not, because often the debate is when we look at QI, for example, is this research, is it not research? And somehow that label makes a difference. And we decided that the label should not make the difference. It's the substance behind it. So we're going to call it research and then see how this plays out. So I mentioned we made some videos. These were animated videos. We also have a website that you're welcome to go to that describes our study, has all of our papers on it, has our survey instruments. Also, it's meant for the general public to explain what these issues are. And our videos also use animated illustrations, and our website also has the same illustrations as comics. And so you can go in there and look at that more. And what I want to do now is actually show you one of the videos. And I'm going to do the second one. They're each about 3 minutes long.
This is Robert. He's a medical researcher. His job is to compare different medications, procedures, and lifestyle choices, like diet and exercise. Robert is going to help the doctors answer their question. Remember, all 3 medications do work to lower blood pressure, and doctors can choose to prescribe any of these 3 medications. But what if medication A works faster than medication B and C? Or medication A is stronger than medication B and C? Or medication A is safer than medications B and C? Robert helps to answer these questions. His work is called Research on Medical Practices. Robert does not replace your doctor. Your doctor is still responsible for your care, but your doctor works with Robert using different research methods to find out which medication is better. Medical record review is one method Robert can use to compare medications. Simply by reviewing medical records of what medications patients are on, he can sometimes find out which medications work better compared to others. Reviewing medical records can be useful, but by itself sometimes leads to the wrong answer about what medication is best. Randomization is another research method Robert and the doctors can decide to use to overcome the limitations of medical record review. But what is randomization? Imagine a gumball machine. You put in a quarter and then a gumball comes out. The color of the gumball that comes out is decided by chance, but no matter what color gumball you get, you know it's a gumball. Randomization means a patient is assigned a medication by chance. Some will get medication A, some will get B, some will get C. In medical research, randomization is the gold standard for making comparisons. So how does this look with patients? Robert randomly assigns one of the medications to each patient. Robert can track the groups of patients to see which group does better. Sometimes the doctors and patients do not know which medication has been assigned, but in many studies, the doctors and the patients do know. No matter what, if a patient does not respond well, the doctor can change the medication. And rather than randomizing individual patients, sometimes entire clinics or hospitals can be randomized. This can be a better way to answer some questions.
So actually, let me tell you one more thing before I move on from the videos. And the videos we used in our focus groups as well as in our surveys, and we actually use the focus groups to not only address questions about these issues, but also to refine the videos and get feedback. And one of the things we were interested in was how well this gumball metaphor worked. And in general, people liked it, so we kept it. In December, I had to do a presentation at the Institute of Medicine on our project, and when I showed them the gumball video, they actually, as you can imagine, they were quite critical of it. And there were two criticisms. One is that gumball machines are not equally distributed across the United States, so it's not a very good metaphor. But more importantly, as somebody pointed out, as their 7-year-old knows, no matter how many quarters you put into the gumball machine, you never get the color you really want. But in fact, I think the gumball machine is better than flipping the coin or having a baby or other types of choices that we can use for thinking about this. But this was really the challenge, how to think about these issues. The other thing I'll mention is that in terms of our collaborators who helped us make these videos, the illustrator is a pediatric allergist in Chicago who I met at one of the bioethics meetings, who as a side hobby likes to draw. And he's the one who did these drawings. And we're now collaborating with him on a second project. He's now working on 2 other projects with people in bioethics and other places who are trying to use this type of video as a way of providing information. So it's been a really fun collaboration with them. So let me tell you briefly about those focus groups that we did. Those focus groups were done here at Seattle Children's, as well as at Stanford, as well as at University of Washington Medical Center. Here we recruited people from cardiology and nephrology, and I certainly thank our Steve Seltzer and Raj, I'm blanking on his last name now. Muncie, yes, who helped us recruit. So let me tell you what we found out. So patients appreciate that practice variation does exist, but they trust their doctors to make the right medical decisions for them. And that their trust in their doctors really is what's central to their willingness to participate in things like ROMP. We talked about medical record review, and what's really interesting there is that they assume this is going on. They would love to have their data shared with other people, other doctors, but no one ever tells them about that. But they think it's a good thing. This is actually a debate I've had for 20 years ago with the CF Foundation, whether we should have informed consent for the Cystic Fibrosis Registry, because it's probably a good idea to let people know what we're doing. They want to know. The other thing that we learned is that they really had a difficulty distinguishing between ROMP versus randomized trials for new drugs. And I'll show you some examples of that from our focus groups. We tried as hard as we could in our materials to try to address that issue. I'm not sure how well we succeeded. That, to me, was one of the biggest challenges. They generally wanted to ask their doctors to ask for permission, their doctors to ask them for permission for both of these activities. And this is one of the issues that we tried to validate in our larger quantitative style. They also said that they didn't want to see a long consent form. They just want to have somebody talk to them. So these, again, were questions that we tried to look at further in our study. I do want to share with you 3 quotes, though, from the focus groups. The first is one from here from Seattle Children's. My son is 16, and we've had 16 years worth of improved medical care because of other people taking the steps and doing the research and improved options for him. So I want to be able to give back to that. Another one about trust. So him coming to me and saying, this is what I'm going to do, I don't need to sign anything. I have a great relationship and I trust him. That would be enough. My favorite one, also from Seattle Children's, about concerns about randomization. I think randomization with a blind aspect is scary, and I would not prefer it by any means. It makes you feel like you live in Cuba or in Canada. It's just a random number, a random person, and here's your random wide pill. Take that. It just seems so sterile and so unfriendly. It's foreign. Now, we continued what's nice about a focus group is that you can really learn what people are thinking, and then you can discuss it with them further. And for those of you who know me, I like to have discussions. And so we talked more about it, and we clarified a few things, and within 5 minutes, you said, oh, that sounds fine. But it shows you where people are coming from and how they think about this stuff. So what I want to do now is share with you the data from the empirical quantitative survey we did across the country based upon our focus groups. And as a pediatrician, this was the first time I've had a paper published in Annals of Internal Medicine, which was a lot of fun to do. I did have to convince the folks at Markham here that because this was published in Annals of Internal Medicine, it was still relevant to pediatrics because they were initially stumped by that one. But let me tell you about some of the findings that we had. And And first, I'll tell you about the approach that we used. As I mentioned, we had our focus groups, we did cognitive interviews, we revised our videos after that. We worked with a survey firm to find a national representative sample based upon geography, race, gender, ethnicity. We used web-based entry for this. We began by having a few questions about trust. We had 3 videos interspersed with questions about knowledge of ROMP as well as attitudes about the research. And then we had scenario-based questions. And I'll tell you more about the scenarios in a few moments, because we really asked them about these different scenarios and their approach to risk and consent for those. So we had 2 scenarios, 2 major scenarios. One was about medical record review, and we had 2 randomization scenarios. And the idea in the medical record review is that the clinicians decide which drugs they're going to use. In the randomization, all newly diagnosed patients are randomly assigned. And we specified newly diagnosed because one of the things that came up in our focus groups was the realization that people were more reluctant if things were working for them to be in a trial. But if it was a new drug, they were much more comfortable with, they don't know what's going to work. So we decided to specify it that way to do this. We also decided, in part because of our friend from Canada, or Cuba, to say, in this case, you will know which drug you're receiving. You'll still be randomized, but you'll know which drug you're getting. And that the clinicians will provide the usual follow-up and change medications if the patients have concerns, if the doctor has concerns. So this is meant to be more like clinical care. Rather than a very rigorously controlled randomized trial, this is more what we often is described as pragmatic trials, in which we really are trying to mimic the approach that we would have in clinical care. As I mentioned before, we had close to 1,100 people that were relatively distributed by a variety of factors. This group was slightly more educated than the general population, had a slightly higher income level. And so let me tell you what some of the results were. First, there was significant support for the idea of ROMP, that they thought, in general, most people agreed that health systems should do this type of research. They also thought that using randomization was an acceptable way of doing this. But what we really were most interested in, though, was this question about their preferences for notification and permission. And we asked them to choose between whether they would prefer no notification, we could just do this, have general information posted on the clinic wall, or as we have here in the lobby with these giant life-size pictures, we have information like that about that this research is going on here. Or we could have discussion and verbal permission by somebody, just having a conversation, but not the requirement to sign a document or having a signed document. And we had 3 different scenarios: a medical record review, randomization using hypertension, but also with a more serious condition. And what I think the main thing to point out is really, if you look at the bottom one, is that regardless of which group it was, most people preferred discussion written permission. One of the interesting challenges of, while there's a value of doing quantitative research versus qualitative, because you can get to more people, we don't know why they said that. And I'll explain later. We actually did some follow-up interviews later on with some participants in one of our studies. And it turned out that the issue here for most people is that they wanted to have something in writing they could take home with them. So in our next study that we're doing, we're now distinguishing written information versus written permission, which we learned from this study. But the question is, what do we do with this? So there's one consultant who was not listed on our previous slide that we at least figuratively consulted, Mick Jagger. And sometimes you can't always get what you want, but you might just sometimes get what you need. And so the question we had asked our respondents later is, what if we can't get your preferred approach to this? What would you do then? And so this is a slide that I realize you can't see from a distance. I want to just tell you in general what's on this slide, and at the end have you focus on what's on the right here. But the main idea here is we asked them a trade-off question. We asked them, what if the approach you wanted would make this too difficult, would you be more willing, would it be okay to do something less than you had preferred, or would you rather the research not be done? And when we asked this of people who first had written permission, and then if they said verbal permission, we said, well, what if that won't work? And if they said verbal permission, what if that won't work? And when we add all those up together, what we can see is that somewhere between 25 and 40% would prefer the research not be done. But that also conversely means that most people would prefer the research could be done, even if they couldn't have their preferred approach. So that was actually the most important, from my perspective, the most important finding of our study. What I want to do now is bring us back to the comparison with the other study we did, which I didn't really tell you about in too much detail yet, which was our members of an organization called Primer, which is an organization that IRB members as well as human subjects research professionals belong to. And we did a survey in collaboration with them of their members to find out their attitudes about these same questions. The surveys were not identical, but we did our best to try to look at how they were related. The important thing to notice is that there was not a whole lot of distinction between these different approaches for potential subjects between medical record review and randomization, or randomization with a more serious disease. But when you look at Primer, we asked them too, what was the minimally acceptable approach and what's your preference for the best approach? And what you'll notice is that they make a very big distinction between medical record review and randomized research, a distinction that patients don't make in the same way that they do. I think the other thing you'll notice is a question that in fact, in general, while they acknowledge what's minimally acceptable, their preferences are for more of this rather than less of this. We also asked them questions about risk. And this is also another area where I think at the end of the day, first we put a lot of time trying to figure out how to ask this question. And we probably went through 10 different versions of very refined questions that just never worked. And in the end, we simply decided to ask them, compared to just having your doctor prescribe these medications, do you think there's additional risk from from this research? And we had 3 choices of none, a lot, or a little. And what you'll see is that there's several things that you'll see. First, you'll see that they do perceive some risk, even of medical record review. And they don't really, while they do see more risk of randomization, it's not hugely different compared to overall. We also asked them whether they'd be willing to consider participating in this type of research. And in general, most people were willing to do this. We also asked them questions about what factors would influence their willingness to participate. And what you can see is that all these factors had some impact. And perhaps the most important ones were knowing you could change the medication and also knowing that your doctor recommended participation. That was also important. Now that, I think, raises a very interesting ethical question about whether your doctor should talk to you and what your doctor should say. We heard this in our focus groups. We heard this in our survey, that they would like to have their doctor make a recommendation to them. We also asked a different question, independent of the recommendation, whom should be the person to ask for permission? And what's interesting is that patients, 85% prefer that their doctor ask for permission. When we asked the folks in Primer, we gave them a scale of least to most preferable. For 52%, clinicians were the least preferable person to ask this question. And so there's a disconnect between what patients are looking for and what Primer members are looking for. Of course, the concern of having clinicians do this is, from the perspective of IRB members, that will put pressure on people to make a decision. This was actually one of the questions I actually asked in our focus groups, because everyone was saying they want their doctor to do this. And the answer was I thought was a genuine answer. And the answer was, look, our doctors make recommendations to us all the time. We don't always follow them. I think we all know that. And so they had no trouble with a distinction between what they're going to do versus what recommendations are made. But in fact, they do want a recommendation. They want to know whether you think being in a study is a reasonable thing to do or not. So the 3 primary observations from our study were that, again, most people support research, they prefer written consent, but if they're in conflict because the research would be too difficult to carry out, most say the research should take place anyway. Their preference is to be asked for participation by their doctor, and they see very little difference in notification preferences for randomization versus medical record review. We're still doing further research in this area. We just completed a supplemental survey of 120 folks in Spokane, Washington, who are part of the Providence Health System. The idea here is, rather than talking to people who are randomly selected because they happen to want to be taking lots of surveys on online panels, we thought we would take people who we knew were active users of a healthcare system with chronic medical conditions. These were all adults, to see how they were different from this other population. There were not a lot of, I don't have the data to show you today because we're still analyzing it. There were not a lot of differences. If anything, I would say this group was more supportive of research and less concerned about research and more willing to participate in research than the general population. We also done follow-up interviews with folks at Spokane to go over our survey with them. And again, part of that was to figure out this iterative process between quantitative and qualitative research, because they always generate new questions. And we started learning more about how things we thought had worked hadn't worked as well in terms of people's understanding of our questions. So now we're doing a new survey in which we have ditched 2/3 of our questions. The other third we've modified and or expanded, including our knowledge section. And we're doing for this next study, one of the questions that had been bothering us is, how do we know whether our video worked or not? How do we know what role the video played? And so what we're doing now is that we are now going to be randomizing people to one of 5 different arms. They'll get the videos we've already used, or they'll get comics based upon the videos, or they'll get what we call a talking head video, which is just my colleague David Magnus talking. Actually, it's not him, it's actually one of our research fellows speaking with a really nice PowerPoint presentation. And then we have text information, and then we have no information. And to see to what extent people's attitudes or knowledge is impacted by which approach we use. So let me conclude with 2 more slides, and we'll have some time for questions. First, I want to come back to that draft OHRP guidance and make some, based upon the information that you saw here, there's some issues here that I think really, if that draft guidance becomes full guidance or permanent guidance, will make it harder to do this type of research. I haven't shown you the data for this, but there's lots of data that suggests that the longer the consent forms are, it actually can undermine comprehension. In fact, and there's been a number of studies of this that show long forms make it harder to understand, and the more you explain, the less they understand. So ideally, we need to figure out better ways of educating people, of communicating to people, conveying information to people. And for those of you who do research, you often will see as the consent forms get longer, they're very difficult to read and process. And so the regulatory way we can address that through the IRB system is if studies are minimal risk, we have opportunities to waive or alter informed consent. We can actually tailor the informed consent form to make it understandable. One of the most interesting examples of this was a colleague of mine when I was at the NIH who had worked at the Dana-Farber Institute in Boston, and she was doing a study of low literacy adults and trying to do some cancer prevention information programs with them. And the IRB's, the consent form was so long, she said, look, this population will not understand this. And it took her 6 months to convince them that if they really wanted people to understand things, they had to let her use simple words. And eventually they did, but she spent 6 months convincing them. Now, the point there is more just, actually there's several points there. First of all, I think often if you talk enough with IRBs, they can be reasonable. We often get intimidated. If the IRB says do this, we do this. And sometimes we can come back and ask for this. And as an example, when we were doing our project in Spokane, the Spokane IRB said, no, we need a 4-page consent form. And I said, you know, you're asking for a 4-page consent form before we do a study about informed consent. That will make it really difficult to do our study. And they agreed. And they changed their mind. Part of it was discussed, we're saying, look, this is minimal risk. It's okay to change some parts of the consent form. It's okay to do this. So the issue, though, is that the implication of the OHRP guidance for ROMP is that we can't waive or alter consent, because the OHRP guidance says that the purpose of the research are reasonably foreseeable risks of participating in this type of research. And so you have to describe it not as a purpose, but as a risk. And therefore, it's minimal risk, and therefore you can't modify the consent form. But in fact, that modification of the consent form, I think, is critical to how we do this. A number of us published a paper in an online publication about this concern, but also making some suggestions of how the consent process could be different. First, it is important to say what the purpose of the research is. It is important to talk about the risks and benefits of those clinical things you're studying as clinical things. And then say the choices for you is whether you want to be in this research or whether you want to receive one of these clinical approaches. I think that's a better way of describing this than talking about these as risks and benefits of the research itself. I'm going to end with one last slide that's actually from an editorial that accompanied our paper by John Lantos, who any of you who come to our summer bioethics course have seen him present there. But he had one sentence at the end of his paper. It's time to ask whether a system in which the fundamental principle is respect for persons can continue to ignore the preferences of many of the persons it claims to respect. So with that, I will end and take your questions. Sure. There's microphones here. Or you can just, either way. Just pull it off, Jonathan, pass.
Ben, do you sense there's a difference in attitude if an adult is doing it for themselves compared to research pertaining to their children?
That's a great question. We initially set out to try to look at that, and we ended up, and we did collect data on people who were parents and not parents in that, but we actually did ask questions about that. We haven't fully analyzed those yet. In general, there were not huge differences. People were slightly more reluctant to do this for other people. And the way we framed that question was not about only children, but just if you were making a decision for somebody else. And I would say that there was some changes, but not a lot.
Are you planning, or did you assess these questions in a cluster randomization kind of way, which is often pretty relevant, say, in public health? So rather than attitudes towards individual participation, say their clinic or entire hospital?
Yeah, thank you. We did not actually ask questions about cluster randomization, which I agree with you is very important to ask about. Part of the challenge was deciding what scope do we want for the survey, and how many questions can we ask. And if you notice, the video I showed you did mention cluster randomization. One of our favorite mantras during the course of the development of the study was reducing cognitive burden. And we realized that as we ended up scaling back so many questions out of our survey, we actually never even got to the issue of cluster, because we decided in this one that was, even though we had the content to explain it, we had other priorities that we really wanted to focus on, so we did not do that in this study. But you're absolutely right. That's an important thing to understand what people think of that. Greg.
I just want to comment. How many of you know what cluster randomization is? Raise your hand. Very good.
Well, we did show it in the video.
One of the things you did was to educate people that you were talking to. And I was curious, if you had not shown the video, and people don't learn these concepts the way you're portraying them, and you go ahead and offer consent and discussions of risk, do they have any clue what you're talking about?
Well, that's what we hope to find out, Greg, in the next study, in which we kind of randomize people to no information versus different ways of approaching the information. And so I think we actually, in the first version of the study, we had 6 knowledge questions. In the new version, we have 18 knowledge questions. And so we're hoping that by having these more knowledge questions, we can distinguish better between what the role of information is or isn't and how they view this. Does that answer your question? You wanted to say more?
He does.
We can have this discussion offline, but I think a lot of this is the assumptions we make about what patients understand when we actually go through the consent process. And we don't do a primer on randomization. We don't do a primer on standard of care.
Right.
I mean, we don't define our terms,
Right.
and I suspect if you hadn't given this talk, we'd all have different definitions of some of those anyway. So among the people who are providing the consents or talking about the consents, I'm not sure we would have a standard response to some of your things without seeing the video.
Right. Oh, yes, I see your point. So in other words, what you're just pointing out is that in actual practice of doing research, we talk about these things and we may explain it briefly, but we don't know whether people understand it or not. And I think, in fact, when we made these videos, we actually were intentional, thinking that one possible opportunity might be for these videos to themselves be freestanding, and opportunities for people just to see these as an educational thing, which is why we created our website. We're now doing a new project in which we're looking at the issue of electronic medical record research, and which also is going to have 6 different videos in it as part of a survey. But also the intention is to make those freestanding, we're also making those videos in 6 different languages, because part of what we're trying to do is to assess whether there's different approaches to research based upon people's different culture and language background. And we also hope that will be helpful. I'll mention for that video, we always, part of the fun is thinking of the metaphors. And so we had the gumball machine, the first one. And so for this one, for electronic medical record review, we talk about the library of medical information as this metaphor for how we collect this information.
Thank you, Ben. I was just curious, in your experience, so the past couple of years, I guess I've been getting bronchoscopy informed consents, and I explain the procedure, and I always say, take all the time you want to read the form, and universally, not a single time someone has actually read the form. So I don't know if you, in your experience, how things maybe have changed, if at all, through your career in terms of people reading it, maybe as people get more educated online with all the different resources that are available.
So I'm going to thank you. So now this is more of a general question about clinical consent. And I think, in fact, one of the debates about this whole support, and I'll come back to your question in a very specific way in a moment, but I'm going to give you a piece of background first. One of the parts of the debate was that the approach for research-informed consent is so much more organized and literal, and the clinical approach is much more variable. And while one of the concerns I have is that the research approach is way too complicated, the clinical approach is pretty suboptimal in and of itself. And those forms really don't say anything really substantially useful many times. But yet informed consent is really important. It's really important to have those conversations. So I actually want to share with you a personal experience I had because it really left an impression on me. As many of you know, I had surgery about 6 months ago. I had a thymoma removed. I guess only a pulmonologist will get a thymoma. And to make a long story short, though, when I had to meet with the surgeon, he had this really, I think, interesting approach to informed consent. First thing he did is he asked me, because I came there by myself, he goes, "Do you want me to get your wife on the phone?" Which I was quite impressed by in and of itself. And I said, "Nah, it's okay." But then he goes, "Well, I'm going to write this out for you so you can bring it home to her." And the informed consent included a blank piece of paper. He says, "Here are the options," and he wrote out each word. "Here's what the purpose is. Here is what the recovery time of each of the options are. Here's what the risks are of them. Here's what the relative," and it was like 6 different things he wrote out, just words. And it took him 15 minutes to do this. That was not a lot of time, but that was enough time. And it was really useful having this piece of handwritten paper that described these things. And I still have that piece of paper because it was a very useful thing. And for me, part of it was both the simplicity of it, yet the time it took, and it was a conversation. And there was something in writing, but it was not about me signing a form. It was about me understanding it. And that really left a very interesting impression on me about informed consent. So, Anne.
So you and I have had a lot of discussions about informed consent at length. And so in my second foray into industry pharma study, the consent form from the company is 24 pages long. I am not allowed to change it without going back and forth with the company. We suggested, since it was so long, could we do a brief patient information form? And they said, well, we'll have to approve that too. And by the way, when is your IRB going to be done? So we don't fight back. So I guess the question is, I can't fight back with this one study because I've got to get it through and we need, and then that sort of observation that patients want their providers to talk to them, but the IRBs don't. And I understand that. So what are your recommendations for sort of going forward from this and pushing back to a certain extent or making changes if we could?
So I've got, thank you, Anne, for that question. I've got 2 suggestions. One is I think the idea of making that supplemental information form is a worthwhile thing. And I think that's the thing I would actually make the suggestion to do, is just to, in fact, actually on one of the projects I'm doing, I was, interestingly enough, this is a different project related to genomics and carrier testing. We have a very long informed consent form, and I was trying to convince my colleagues to have a shorter form, and they wanted a longer form. And so, but in the end, now 2 years later, I've been able to convince them that we need to have a 1-page summary. But one of the things I also mentioned in that 1-page summary that I have found very useful when I make these 1-page summaries is to include, here are 3 reasons you may want to participate, and here are 3 reasons you may not. And that allows people to look at the information and prioritize things and decide which of those reasons are important for them. And that can be a way of providing some balance. With regard to the issue of the provision of consent by clinicians, I think that's an ongoing debate. And I think that different IRBs have different approaches to this, and we've discussed this at length. But I think this is an evolving issue, and I think we just have to sort this out and think through creatively how to do that better.
One thing that interested me is that you showed.
Would you make sure it's on?
That should be better. One thing that interests me is you showed a figure that showed almost equal perception of risk from medical record review to a randomized trial.
Right.
And I was wondering if any of your focus group touched on whether that was a kind of misperception of risks, or if the participants actually had different prioritization of risk compared to researchers, because I think most researchers would acknowledge that a medical record review is less risky in general than a randomized interventional trial.
Yeah, well, yeah, thank you for bringing that up. I think we think there's a number of different things going on here. And some of that came out of doing the interviews, following up with the Spokane folks. And I think that one of the things, the number of different things happened. In spite of our description of medical record review, what we learned is that some people thought we meant by this, even though we showed our videotape, is that they would review your medical records and then make a decision about how to treat you based upon that review. So they were viewing medical record review as an active process rather than a passive process. So that might explain some of it. Other is that the word risk means different things to different people. And it's a very Gestalt term. And so in our next survey, we're actually not using the word risk as we tried to assess these terms. We're using other words because we realize that risk itself is very complicated. I think the third thing as a substantive issue is that often, and this I think was going on with OHRP, we don't know how to talk about things other than calling it risk. And so OHRP was correct, I believe, in saying it was important to help people understand why this research was going on, what the alternatives are. But the only way they know how to describe it is by calling it a risk. I think people do the same things. So when people say they see risk of medical research, I believe, a medical record review, I think for some of those people, most likely what's going on, that's their way of saying, we want to know about it. And so they make that connection between the two. I don't think it says about the risk. I also think it says that risk is not the central issue in thinking about how we choose to engage people about research. And so for me, whether it's medical record review or randomization, I think when there are opportunities, I think we ought to be letting people know when we can about medical record review. They would like to know that, not because they want to say no, but because that's really cool. This is how they can be contributing more than their own care to improving healthcare. And they want to know about these activities, whether it's themselves doing it or how we do it across the institution. They want to know.
I'm going to take moderator privilege and say, I think we as human beings have real difficulty with the concepts of risk. I'm very involved in what are we doing about immunization and immunization risk, and parents who decide that it's too risky to take MMR because it may or may not have subsequent consequences. But if you ask the same question, so you're going to let your 16-year-old that you've just now had go through driver training be in charge of a 3,000-pound missile, immediately that risk is much lower. Except the data says that if you're female and you're 16 and you've done driver training, you have an 80% chance that you're going to crash the car in the next year. If you're male, that's over 95% that you're going to crash the car in the next year. Those are such orders of magnitude difference in risk assessment that we internalize all the time. So it's a big challenge for us as we start trying to talk about policy and how those policies are going to be impacted.
Just a comment, not a question. But I think another thing to think about when thinking about risk and kind of informed consent is the cultural differences that exist with the concept of choice. And I think particularly if you think about choice in the West versus the East and how different that is and who makes that choice and where that responsibility lies and what information informs that choice, I think that this conversation becomes even more complicated.
Thank you.